Welcome back, guys. So in this video we are going to review gastrointestinal bleeding, also known as GIP. We can separate the gastrointestinal bleeding into two main locations, the upper gastrointestinal bleed and the lower gastrointestinal bleed. All this will be related to Treitz ligament, which separates the duodenum from the jejunum. So if the bleeding is proximal to it, it's upper gastrointestinal bleed. If it's distal to it, then it's a lower gastrointestinal bleed. Now let's review the symptoms of this bleed. If we have an upper gastrointestinal bleeding, then we will have hematemesis, which means we have blood in the vomiting. The patient will mention that he is vomiting bloody materials. Coffee ground emesis, it means we have digested blood in the vomitus. So because of that, the appearance of the vomiting will appear as a coffee ground. For the lower gastrointestinal bleed, it could be either upper gastrointestinal or lower gastrointestinal bleed. So we can find this in both of them. We have fresh blood per rectum, we have melena, we have hematochezia. Hematochezia, it's mixed blood with stool, so it's a maroon colored stool. For melena, it's a black or tarry stool. It can reflect upper gastrointestinal bleed or right column bleed. Fresh blood per rectum is just fresh blood appearing from the rectum or oozing from the rectum. Sometimes they might mention this. So when you face a case of GI bleed, the next question should be, is our patient stable or our patient is unstable? So always look into the china to remember the cause of shocks. We have cardiogenic shock, hypovolemic shock, or in our case is the bleeding, infectious shock, septic shock, neurogenic, and anaphylactic shocks. So these mnemonics help us to remember the kinds of shock. So because if it's hypovolemic, we have a hypovolemic shock because of the bleed. So we look at the heart rate and the blood pressure, the systolic one, and the hemoglobin. For this heart rate, more than 100 and systolic blood pressure less than 100, it indicates we have a severe bleed. If the heart rate only is above 100 and the blood pressure is well controlled, then we have a moderate bleed. If the hemoglobin is taken, sometimes it might appear normal, especially at the acute phase of bleed. It will appear normal because the body has not yet reflects the changes of hemoglobin. So the first thing to change is the heart rate, then the systolic blood pressure, then the hemoglobin will drop. So for the heart rate, always remember if it's more than 100, it means that we have more than 10% of blood loss. It might appear normal if the patient is taking beta blockers. For orthostasis, it's a sign that indicates a change in systolic blood pressure or diastolic blood pressure when the patient changes position from lying down into standing position. It indicates 20% of blood loss. For the shock, it means we have a heart rate more than 100 and systolic blood pressure less than 100. It indicates that we have more than 30% of blood loss. So the first step is to stabilize unstable patient and resuscitate the patient with fluid to make him stable, to be able to detect the location of the bleeding. So if the patient is unstable, we need 2 large bores IV. Large bores mean 18 gauge or larger. The higher the number of the gauge, it means the lower the narrow of the needle, and vice versa. So if we have a lower number, it means that the needle is larger. So we resuscitate the patient to maintain a systolic blood pressure more than 100 and heart rate less than 100. So we give normal saline or Ringer lactate as a fluid. Also, we monitor the urine output to determine the hemodynamic status of our patient. For the labs, we order hemoglobin. Remember, it might appear normal during acute phase of bleed. If it's less than 7 grams per deciliter, we transfuse no matter what. If the patient has hemoglobin of 8 and he is bleeding, we transfuse. So at 8, we need bleeding to give blood. Remember always that early bleeding might present with a normal hemoglobin. I said that 3 times. For the hemoglobin of 8 and bleeding, we give blood. Remember, the 8, it looks like capital B, so we need bleeding with hemoglobin 8 to give blood. So between 7 and 8, we need bleeding to give blood. For the platelets, if we have less than 50,000 platelets count and the bleeding, we transfuse platelets. Otherwise, we don't give platelets unless the count is less than 10,000. In some hospitals, they say less than 20. For the board, take 10 as the number. Then we transfuse if it's less than 10,000 to prevent spontaneous bleeding. So for the platelets less than 10, we transfuse no matter what. And for hemoglobin less than 7, we transfuse blood no matter what. Then we look at the INR. For the INR, to fix it, if it's elongated in bleeding, we need a value more than 2. Remember, we have the fresh frozen plasma and the PCC, prothrombin complex concentrate. The main difference between them is the volume. Fresh frozen plasma, it's has much larger volume than the PCC. PCC, it's a concentrate, so it's concentrated, so it has less volume. Remember this. So if the INR is more than 2, we need to check the patient's medication and to make sure that the patient is not cirrhotic, and then never answer if you see INR more than 2, never think of vitamin K as an option. And the reason is that the liver needs time to make coagulation factors with vitamin K. It takes up to 12 to 1 day to make this coagulation factor. Remember, all the coagulation factor are made up in the liver except for factor 8 and von Willebrand factor, which are made in the endothelium. So if the patient is taking warfarin, you stop the warfarin and you give PCC or FFPs. And if the patient is cirrhotic, you give them also to correct the INR. For if the patient is taking DOACs or NOACs, the direct oral anticoagulation medication or a novel oral anticoagulation medication, we can reverse them. We have andexanate for factor 10 medications like rivaroxaban, and also we have idarucizumab for dabigatran. Remember the da in idarucizumab and dabigatran, you give it to reverse it. So remember, you get IV access, cross and match, basic labs, and also remember that the gastrointestinal bleed, it might increase the BUN, the blood urea nitrogen, because of the digested blood, and also it might present as an acute kidney injury as a prerenal cause because of the hypovolemia secondary to bleeding. So remember these tricks as you solve questions. Now, after stabilizing the patient, you can start investigating the cause of the bleed and give targeted therapy to the cause of the bleed. Now we will review the upper gastrointestinal bleeding as causes and what there are therapeutic options to treat each case alone. So remember, as an upper gastrointestinal bleed, it has, as the definition says, it is bleeding upper to the ligament of Treitz, so it includes the esophagus, the stomach, and the duodenum as the location of the bleed, and lower it's it's distal to the Treitz ligament. Now, causes of upper gastrointestinal bleed include peptic ulcer disease, erosive gastropathy, esophageal varices, and esophagitis, and Mallory-Weiss syndrome. We'll discuss most of these disorders. Also, gastric cancer and esophageal cancer might present as gastrointestinal bleed. Remember this. Now, for peptic ulcer disease, always remember the rule in gastrointestinal bleed. We stabilize the patient. So when the patient is stabilized, we give PPIs. We can give it either BID or via drip, IV drip. Then we do EGD to diagnose, and sometimes to do therapeutic options such as cauterization and epinephrine injection in case we have visible vessels or an active bleed. We do cautery, and sometimes we take biopsies to assess the ulcers. Remember, so we stabilize PPIs and EGD to therapy as a diagnostic tool and yet therapeutic tool. Sometimes they might mention to place an NG tube to locate the site of the GI bleed, upper versus lower. This is not done. It can miss up to 10 to 15 patients. Don't answer this on your day of in your exam day. Don't answer. It's always the wrong answer. Sometimes in clinical life they do it on the day of the exam. I don't think this is a clinical pearl that you need to know and to do on your day of the exam. Erosive gastropathy, here the mucosa, it's facing a stressor that will cause stress-induced injury. So we have NSAIDs, aspirin, cocaine, alcohol. Sometimes they might mention Cushing ulcer. Secondary to CNS injury, remember thinking, Cushing. Or burns patients, burning, curling. So burn and cur, Cushing, thinking. So we think with our CNS, so CNS injury. They might cause ulceration, especially if the patient is admitted to intensive care unit and he is on steroids. It will add more stress. Usually we stabilize the patient and we give PPIs and to prevent this, and we correct the underlying cause of the erosive gastropathy. Now, for esophageal and gastric varices, the etiology beyond the esophageal varices is that the distal esophageal veins drains the blood through the left gastric vein, which is a part of the portal vein. However, when we have portal hypertension in cirrhosis, that's a risk factor to have esophageal varices. However, not all cirrhotic patients have this, and not all the esophageal varices patients, they have cirrhosis. So one of the causes is cirrhosis to have esophageal varices. Remember, if you saw isolated gastric varices, to think of splenic vein thrombosis. The spleen drains its blood through the splenic vein. However, if this is obstructed by thrombosis, it will shift to the small gastric veins, which it drains through the stomach walls into the left gastric vein. So when we have thrombosed splenic vein, we will have engorgement of the small gastric veins, and will give us the gastric varices. Regarding the esophageal variceal bleed, for the treatment we do preventive treatment and acute treatment. For the preventive, remember A and B. A for antibiotics and B for beta blockers. We give antibiotics to prevent spontaneous bacterial peritonitis. We give ceftriaxone, fluoroquinolones, levofloxacin, ciprofloxacin. For the beta blockers, we give propranolol or nadolol. For the acute treatment, we stabilize the patient. We give octreotide, EGD and banding, the varices and tips, transjugular, intrahepatic shunt. We will discuss it later. Now, if we want to treat cirrhotic patient with variceal bleeding, we stabilize the patient. We follow the first rules that we mentioned. We give fluids, blood, we correct the INR, and then we give octreotide. The function of octreotide is to decrease the portal hypertension. So the mechanism of action of octreotide is that it decreases the portal pressure via splanchnic dilatation of the abdominal vessels. Remember again, for gastric varices, isolated gastric varices, to think of splenic vein thrombosis. And again, the mechanism of that is that the spleen drains its blood supply through the splenic vein. However, when the splenic vein is obstructed secondary to thrombosis, this will force the blood to go through the small gastric veins into the left gastric vein. This shift of blood from the splenic vein into the left gastric vein through the small gastric veins will cause engorgement of this vein, and hence we will have the gastric varices. So whenever you see isolated gastric varices, the answer is splenic vein thrombosis. Don't forget that. And again, we give antibiotics. We have the fluoroquinolones or the ceftriaxone. We give beta blockers as preventive therapy, also nadolol or propranolol in cirrhotic patients with variceal bleeding. This is the preventive therapy. And of course, we do EGD for variceal ligation or sclerotherapy. The final step, if all this fails and the patient has recurrent bleed or persistent bleed, we do something called the TIPS, transjugular intrahepatic portosystemic shunt. So the main idea of this procedure is to overcome the portal pressure by connecting the portal vein with the inferior vena cava, and this will allow blood to go from the portal vein into the inferior vena cava. What happens is the portal triad. In the normal patients, the blood goes from the portal vein branch into the inferior vena cava branch. This structure is destroyed. You don't see this hexagons in cirrhotic patients, and this will allow portal hypertension to appear. In the TIPS procedure, we insert the catheter through the jugular vein into the inferior vena cava, and then we connect the inferior vena cava with the portal vein, and this will decrease the pressure within the portal vein. However, this will increase the risk of hepatic encephalopathy, as ammonia is not cleared by the liver, so we are bypassing the liver. However, we use TIPS in recurrent variceal bleeding or persistent variceal bleeding. Thank you for watching, and good luck guys in your examinations. We will upload more videos in the upcoming days.